I suspect that most of you know that October 20th of this past year, we had a multi-society, state-of-the-art consensus conference on prevention of bile duct injury during cholecystectomy. And so what we hope to do today is really to provide you with an update on that meeting, which was a full-day meeting, and then talk a little bit about next steps. My name is Michael Brunt, and I'm at Washington University in St. Louis, and my co-chair for this session is Dana Tellem, who's at the University of Michigan. So this is my disclosure slide, none of which relates to any of the content. So these were the goals for the consensus: to identify optimal strategies for bile duct injury prevention during cholecystectomy and to help develop and disseminate evidence practice guidelines. This was a very extensive process. So in 2014, we started the SAGES Safe Cholecystectomy Task Force. And in 2016, we had a joint session at an international HPB meeting on this topic. And it was after that that we formed this multi-society task force and steering committee and began the process of developing the process for the consensus, which was really quite extensive, and you're going to hear more about that. There was a steering committee formed with representation from leadership of all of the participating societies, as you can see here, and additionally, we had a number of other key individuals who were involved from SAGES guidelines, methodologists, biostatisticians, and support staff. I'm sorry, let me go back. It was a pretty rigorous methodology. You're going to hear a little bit about that. There were numerous conference calls, and we had an in-person retreat where we sat down, went through each of the questions that were developed. This was after there had already been a pretty systematic literature research, abstract review, paper review, data extraction and analysis. And then that's when we started coming up with the evidence-based guidelines. And then ultimately a consensus conference with expert voting, and we've had a period of public comment afterwards. We had 6 work groups that addressed the various questions with leads, co-leads, and a number of other members who are involved in the data extraction. And then an expert voting panel with representation from all of the societies, in addition to Rural Community Surgeons Group, the American Association for Surgery of Trauma, and the Endoscopic and Laparoscopic Society of Asia. This conference was funded by an R13 conference grant from the NIDDK, as well as SAGES Education and Research Foundation, and we had industry grant support as well for that. The meeting itself, we had over 170 attendees, 28 countries represented, 26 expert panelists with voting participation, and approximately 90% of the recommendations were approved. Approval meant that there was greater than 80% agreement by the experts, and there was high concordance with the general audience voting. I'll show you a little bit of that data later today. And we also came up with a number of Type B recommendations for future research studies that were prioritized. You may have seen the lead article in General Surgery News from a couple of months ago that summarized a little bit from this conference, and I would be remiss if I didn't mention that we do have a series of didactic modules that are out on the SAGES website around safe cholecystectomy that are narrated and have a lot of photographic and video content. They're freely available to anyone, so I'd encourage you to go out and to take a look at those, and not only that, but to promote their use within your institution and your residency training programs. So with that, I would like to introduce the first speaker, who is Dr. Stephen Strasberg. Dr. Strasberg is professor of surgery at the Washington University School of Medicine in St. Louis. He's been a leader nationally in HPB surgery and, of course, is widely known for his work on the critical view of safety. And he's going to talk a little bit about the process methodology and go into some depth on one of the recommendations to give you a sense of what we went through for this. Steve.
Good morning, ladies and gentlemen. My task is outlined on this slide. Michael's just told you we're going to talk about the methods we used to develop questions and to answer them, and we're going to use one of the questions as a way of illustrating a particular topic. in 12 minutes. When we started 3 or 4 years ago, we had a whole series of questions which we thought might be interesting. A lot of these questions were like this: what's the incidence of major bile duct injury? What are the types of bile duct injuries? But we scrapped these kinds of questions because we wanted to have questions that would affect practice directly. And to do that, we made a decision to concentrate on guideline development and to use the grade method of guideline development. In this, we were quite influenced by Dimitris Stefanidis, who is the head of the guideline development SAGES and a member of the group. So this is an overview of grade. I'll just take you through it a little bit. The first step in grade is to create questions. I'm not getting the next slide. Oh, okay. So there's type of questions is a PICO question. PICO format questions stands for population, intervention, comparator, and outcome. And here's a PICO question down at the bottom part of this slide. The population are patients with acute cholecystitis. The intervention is early cholecystectomy. The comparator is delayed cholecystectomy. And the outcome that we're studying is the risk and severity of bile duct injuries. We came up with 18 questions in 5 categories, looking mainly at questions focused on the prevention of bile duct injury. These questions were under the headings of anatomic identification in cholecystectomy, how that influences bile duct injury, the role of disease and patient factors, place of surgical techniques other than laparoscopic total cholecystectomy in preventing bile duct injury, the role of the surgeon and education of the surgeon, and the one that wasn't on prevention was on the management of bile duct injury. That was PICO 18. So once we have the questions, then the questions are looked at by going through the literature and performing a systematic review of the literature when necessary. Sometimes the systematic reviews were already available, and this leads to a summary of findings of the papers, and following that, excuse this, we rate the quality of the evidence, and when the quality of the evidence is rated, randomized controlled trials start high. They have high levels of evidence, and they are graded down if they have some of these problems, risk of bias, publication bias, for instance, whereas observational trials are rated low. Observational studies are rated low to start with and can be graded up depending upon the factors such as a large effect and dose response. The last step is the creation of the recommendations, and the recommendations are based mostly on the quality of the evidence, but there's other things that can affect the recommendations, such as the balance of benefits and harms, and values and preferences. The classical thing being you don't recommend blood transfusions as a strategy when the population is Jehovah's Witnesses. In the 18 questions, it was expected that much data would be available for some questions, while little data would be available for others. Data-rich PICO questions are much more likely to result in useful recommendations from the grade review. For instance, there's a lot of information on when to operate in acute cholecystitis, early versus late, while we expected that that some questions would be data poor, but this would provide us with an opportunity for future study. And some examples of this were, does coaching or simulation reduce bile duct injury? We didn't expect a lot of data there. So as already mentioned, there were 2 types of recommendations: a grade A recommendations, which flow from the data in the grade process, and current available evidence supports the recommendation. Type B recommendations flow from the recognition of deficiencies in our knowledge, which are also identified or uncovered during the grade review, and these recommendations relate to studies to be done or study methodologies in the future. And I know you can't see this very well, but don't worry about it. I'll take you through it. This is from a systematic review of several meta-analyses of randomized controlled trials, 18 randomized controlled trials, and these are the meta-analyses. And these two had the most data because they were the most recent, and they encompass most of the randomized trials. We actually relied heavily on this one from Australia. And we're talking now about systematic reviews and meta-analyses of the question, should one operate early or should one operate after a delayed period in acute cholecystitis? And while our review was going on, a very important study came up from Sweden, from a clinical database with over 600 bile duct injuries. And they showed that the adjusted risk of bile duct injury was doubled among patients with acute cholecystitis. And this was almost all due to the fact that patients with moderate but not mild acute cholecystitis had a much higher incidence of bile duct injury if operated on. And this more than doubled the risk of bile duct injury. But importantly, it did not increase the risk 10 times or 12 times. It increased the risk about twice, a little more than twice. So because this is important in the genesis of bile duct injury, failure to consider severity grade in a study may result in first imbalance in terms of severity grade with more mild or moderate severity in one group, so an imbalance in the likelihood of having bile duct injury occur, or the inclusion of one grade over another, the severity imbalance towards mild acute cholecystitis or moderate cholecystitis, in other words, getting not representative samples. So how many timing studies included severity grading in acute cholecystitis? None. There's no timing study, acute versus delayed, that includes severity grading to this point. Part of the reason is we didn't really have the study until 2016 to show its importance. So one of the type B recommendations that came out of this evaluation was that studies that examine the relationship between bile duct injury and acute cholecystitis should match the patients at baselines for severity grade of their acute cholecystitis. Now, this is another interesting thing that we came across. This is from the study of cow, 14 randomized controlled trials. The total number of patients in these randomized controlled trials, the total was 1,608. Now, 1,608 patients, we should be able to tell whether bile duct injury is more common if you operate early, if you operate late, right? Well, not so fast. Here's an example of problem with bile duct injury and its low incidence. In the laparoscopic era, we think the incidence is about 3 in 1,000. In the open era, it was about 1 in 1,000. So major bile duct injuries have aspects of rare and common problems. The aspect of common problem is that there's so many laparoscopic cholecystectomies done that there's 3,000 major bile duct injuries despite the very low incidence. Now let's have a theoretical study of open cholecystectomy versus laparoscopic cholecystectomy in 2,000 patients to see which is associated with a higher incidence of bile duct injuries. So there's a projected bile duct injury rate. Now, how many events will you have in 2,000 patients? 4. 4 events in 2,000 patients is too few to draw conclusions about bile duct injuries. And in fact, Wu, one of the authors of the large meta-analysis that we studied, said this could only be done by evaluating thousands more patients. So there actually is a large population-based study that was published in 2014 from Toronto. Unfortunately, this study used an administrative database which was the one that was available to them, so that was the only one they could use. And the major outcome was major bile duct injury. They used propensity scoring methods to address confounding by indication and concluded that early cholecystectomy was associated with a lower risk of major bile duct injury. However, severity was not accounted for, and there were other issues as well in terms of diagnosis. So we still do not have a large population study that will answer this question. So this is what the de Mistral study looks like in grade. There's 14,000 patients, and there's a significant difference in terms of bile duct injury. But as I told you, this study seems to have a fatal flaw that we had to take into account in our conclusions. Now here's a different aspect to the study, not on bile duct injury, but another variable we looked at, early versus late cholecystectomy on total hospitalization. So here there was 1,300 patients, much smaller than the de Mistral study, but all 1,300 patients were an event. They all had a total hospitalization. And here you can see it's significantly different. So here is a summary of our PICO 8 grade results look like. The certainty is very low because most of the studies are observational. There's no difference between early and late cholecystectomy in mortality, patients with complications, or conversion to open cholecystectomy. Early cholecystectomy is favored for length of stay and wound infection, significantly different. Late cholecystectomy is favored in duration of surgery, and intermediate was a bile duct injury. Indeterminate was a bile duct injury. So in mild acute cholecystitis, early versus late lap chole is unlikely to be an issue because overall rate of bile duct injury is not increased in mild cholecystitis. However, in moderate cholecystitis, the overall rate of bile duct injury is doubled. Therefore, baseline equality in a Tokyo severity grading is needed in studies of timing. Thus far, no adequately powered timing study with the outcome measure bile duct injury has taken severity into account. So finally, I'm sorry I can't read this on this. I'm sorry you can't either. But the recommendation is that when it's mild cholecystitis, early cholecystectomy is favored and it should be done within the first 72 hours. In moderate and severe cholecystitis, there's just not enough data at the present time to make a recommendation. Thank you.